So week 4, this is a week where we cover some, things that's chapters 37, 38, 39, cognitive and sensory impairment, that family-centered care. We're going to go into separation anxiety a little bit. And then the variations, chapter 39, probably of all 3 chapters. Chapter 39, which is actually the biggest, has all of those differences between adult and children and how to care for them. So it's what those variations are talking about. So I'm going to do a cahoots today for class. I'm covering all the concepts you need. If we have a little time, I'm going to go to chapter 39 on the PowerPoint and go over a couple of slides. I don't want to keep you over your time, but I don't want to have you leave in 20 minutes early and we could have, gone over those things because you will see them again. So let's go ahead and do our cahoots for today. There are 48 questions, so we should be right about time, but if not, we'll do something else. And start there. Can everybody hear me okay with no problems? So week 4, we're 1/3 of the way through, one exam down. And I want you to know overall, the scores are actually very good. I was very pleased with what I saw. And even Felicia, who was going crazy trying to download it last moment, biting her nails, you did okay. Don't worry. Because I
Really
checked,
sorry
I'm
about
like, I
that.
don't want her stressing out.
Sorry
So
that I
you
was so
did all right.
prepared.
Was the
Thank you.
class average above passing?
Yes, it was. You guys did great. Overall, it was a really well scored, good curve, but there was more over than under in the grades, if you know what I mean. So yeah, very well done. I always I'm afraid when I have to take a whole week off and leave my class. So you guys did good. Proud of you. Thank you. Early detection of a hearing impairment is critical. Which one is of primary importance? Well, when you think of hearing, what also is connected to it? If you can't hear, what's going to be affected? And actually, when you look at this question and flip it around, another way is that if you have a child who doesn't speak correctly, cannot pronunciate, your first thing you're going to do is a hearing evaluation. So remember, hearing and speech are always connected, okay? So if they don't speak, yes, speech therapy will be ordered, but also a hearing test will be done also. Okay. A toddler's playing outside and gets a laceration on his forearm and he needs stitches. What can make this easier? A toddler, remember, these are ages 1 to 3. He's got a cut, he's bleeding, his insides are falling out of him. That's what they think and how they think. Well, if we put numbing cream on it and let them know they'll feel touch and not sharp, that's great. The other thing is that distraction. Now, Child Life, I don't know if you're all familiar, but let me describe them. Child Life is this group of very well educated professionals that are taught minimum of a bachelor degree. A lot of them are masters and PhDs in this. And what they do is they learn all about the growth of the children, growth and development, and how to explain procedures. They will sit there and know the appropriate things on their developmental level, how to distract them. music or bubbles or an iPad or a crayon or a sticker or a rattle for a baby. They're there, and I'm telling you, they work wonders, especially if mommy can't watch that laceration being stitched because she doesn't like those things. You've got somebody else who can be that way to them and make them feel really comfortable. It's a great group of people. A parent recognizes that their toddler has a speech delay compared to their older siblings. What is your nursing priority? So, number one, priority. Okay. Yes, many of those other things could be, but priority is hearing evaluation, right? It could be just hearing. Then, if we need further speech therapy, or if they can't hear, part of it that would be the sign language. And yes, all children do progress differently, but hearing evaluation first, especially when we're talking how much of a delay. And, that would have to be, if it's a toddler, they can't say 3, 4 words put together by the end, by coming up year 2. So those are things we would look at. A multi. What are signs of an early indicator of impaired cognition, which means their brain isn't working the way it should? And what could cause impaired cognition? The number one cause? Nutrition, nutrition, nutrition. You don't feed the tank, the brain ain't going to work. So, impaired cognition, you would have decreased motor skills, whether they're fine or gross motor. They're not verbalizing. Absolutely. That's one of the big ones. These children, because they have an inability to think correctly, they are they have behavior problems because they can't tell you what they want. They don't know what they want because they can't think correctly yet. And then, of course, that fine motor, they can't grasp objects by 7 months, and they should be putting it, changing hands by then. A child's being treated for a fever. The reason for treating this child's fever is what? Do you have to give this child ibuprofen or acetaminophen? Why do we give it? Why do you take it with a fever? And it's because you don't feel good with a fever, period. You just feel achy, painy. And children, we know once their fever comes down, they're up, they're running around, and they're drinking, which is what we want them to do. So there is usually, when you have a fever, I've seen fevers up over 106, never saw a seizure with them. So once you have that fever, you're actually safe and as long as no seizures have occurred yet. But the main reason is discomfort. Okay. A multi. A child's complaining of something is in their eye and it causing tearing and pain. What should you do? Now, there's all different ways kids get stuff in their eyes. It could be running into a tree and getting jabbed with a leaf, a stick, a pine cone, or falling, getting in there. Or it could just be a little piece of ash or something. So, what the book tells you, if there's any floating objects, you could take this corner of a tissue and remove it. Okay, just put it there and we'll move it. Now, the other thing is, as we're doing our assessment, is looking for pupil reactions. And if we see it big, not moving, small, not moving, that is really cause for alarm. And if there's something sticking inside the eyeball, they say to put a fox shield. And this is a hard shield, it's not gauze, and it covers that area. So it prevents that from being touched by anything. And we would recommend both eyes, actually. so the eyes won't move, and get that child to an ophthalmologist or a pediatric ER as soon as you can. Try to save that eye. Separation anxiety in a child hospitalized, which behavior indicates the stage of despair. Now there's 3 stages. We have that stage number 1 where the kid is yelling, mommy, 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 screaming, yelling. Then they go into a second stage where they regress. They start sucking their thumb, or maybe, they're potty trained and all of a sudden they're not. And the third stage is when mommy and daddy come back, they don't even want to pay attention. So when the separation anxiety, the despair is that second stage, that regressive behavior. They're like, where is mommy? I'm still worrying about that. A child with a history of abuse, which therapy explores emotional problems. Many times you'll see child life helping the psychologist doing these therapies, looking for what's going on with the child, what happened. Because with play, they're not threatened. And it's all play therapy. It's what we could do. Sometimes they call it dramatic, but let's just basically play therapy. Play with the dolls, play with equipment, and let's see what the child does with it. A multi. When can children react to stress and anxiety of hospitalization? So when do they react to it? Many times children know they're going to go in and have their tonsils removed or tubes put in or whatever. And we don't like to tell them too soon, because even before they're hospitalized, they're going to start getting anxious and nervous about it. And parents don't always know all the answers, what's going to happen. But we also know that after they go home, they're also going to be stressed out because we had to stick them with a needle, or they had a pain, or they could have had a bad sort of experience. So stress and anxiety, children hospital is really real, and it's something that we need to look at really close. A multi. An adolescent goes to the ER for treatment without the parents. How do you get consent for treatment? You see this with kids that are older. You also see this with children that are with their grandparents, or they're at their friend's house and that friend's parents brings that child in for some emergency treatment. Well, if a client's 18 and alert and oriented, they can sign for themselves. In fact, at age 18, you as a nurse need to ask the child if you can talk to their parents. And he has to, or she has to say yes. Another thing that we can do is, if it's an emergency, ran over by a car, brought in by a helicopter, you do not need any consent. We're going to do life-saving treatment. You don't need consent, but you get it as soon as possible afterwards. And then there's also, it's not an emergent. You have time to reach the parents, 2 people, and it could be the ER clerks, get a consent over the phone, and they sign okay for consent. These things you'll see on your NCLEX, these type of questions. And I believe there was one on the HESI. A child's extremely fearful about hospitalization. What type of play explores these fear? So this is the dramatic play where you're letting them make their own drama. Let them tell me, what are you afraid of? And maybe figure out what type of equipment that you can safely put in front of them so that they can show you, or play with a doll with it and explain why it hurt. When checking an IV on an infant, you notice that the tissue around the IV is swollen. What's the first thing you do? Now, having worked in NICU for a really long time, and with the cardiacs, which are mostly your neonate, young little infants, we know that 10 mLs an hour for me and you is nothing. But do it to a child who weighs 2 kilos. That is a lot of fluid that could, undermine in the tissue and cause tissue death and necrosis. And we don't want that. Number one, turn it off. Then you can go ahead and check it. But first of all, check it first. Stop it. In helping a child to adapt to a hospitalization experience, the best approach is what? What helps the kid be in a hospital? And it's that routine. It's always that ritualism of what do I do? What time do I wake up in the morning? When do I take a nap? When do I take my bath? What sort of clothes do I like to wear? Do I change my clothes? These things are important to these young kids, especially your toddlers. That's the big one. But then right behind them are the preschoolers. So daily routine schedule, and they know what's coming next. And it makes a big difference. When assessing the vision on a child, the healthcare provider would use the Snellen chart at what distance? And remember, with children, we're not going to have letters. We're going to have different ones that are appropriate. Maybe arrows up, down, sideways, maybe colored pictures. All different things are used depending on the child's developmental age. And yes, it's 20 feet. And if we see any variances to that, that's when we would let the healthcare provider know so they can do in-depth evaluation of that. Another multi. Nursing care of discharging a child to home. Whether they were in the hospital for medical treatment or being discharged, post-surgery, you're sending them home. What do you need to do? So you would also give instructions to the child if they were old enough. Okay, that's why that red one is correct. You need all the emergency telephone numbers, and they need to know what's expected. As after my tonsils and adenoids, are my ears going to be popping and hurting me? And maybe, am I going to have bleeding? What's okay? What's not? Very important. Let the parents be your eyes to take care of them. And then have that parent explain what they're going to do, what they're looking for, what should they feed the child, what for pain, et cetera, et cetera, et cetera. That's probably the most important thing is that discharge. What is the 3-year-old biggest stressor of being hospitalized? 3-year-olds, that's like the end of toddler, beginning of preschool. What's their biggest fear? And it's being away from mom and dad. So as much as possible, there's some confusion of what do you do? What's the best for a child to decrease stress? Well, number one, the parents can stay in room in at night as much during the day as they can. That's what we want. Number two, we're going to do that ritualism. And three, maybe bring in their toys from home. But those things will do that comforting. But number one is always parents. They want mommy or daddy or whoever. A multi. What is the best way to alleviate the stress and anxiety of a hospitalized child? So parents in, same routines, and then again explaining all of those procedures. They have gone away from doing procedures invasive even starting IVs, they will not do in a hospital room. That bed needs to be their safe zone. So there's different procedure rooms that they would take them to. A nurse notes a string tied around an infant's wrist. An appropriate nursing intervention would be, why is a string around an infant's wrist? I know working in Miami, the Hispanic culture has these little cat eye things. Or I got a blue one from a Colombian family. There's black ones, and they put these little things, whether it's a little pin or a little bracelet or a necklace, and it makes people not give them bad vibes. It keeps them safe, and that's what I've been told about it. Same type of thing here. When you see, because it's not usual, right, to have a piece of string of some sort around an infant, there is usually a cultural reason why. And the only time when we would remove it, we'll respect that, is if we have to for procedure, etc. But as much as possible, we'll leave it there. How can a hearing impairment develop? So it could be present at birth, could be some sort of malformation, right? Absolutely chronic ear infections. That's why we need to tell parents to make sure they take the entire amount of antibiotic and also go back and be checked after it's all been given. And we know any sort of illnesses can do those things, put mucus up in the ear and cause it. Plus, there's things that can occlude nerves and whatnot, Tay Sachs disease and stuff. So it can be that illness too. So all of them. Which urine collection method on an infant is most accurate? And being accurate means you get a good culture, you get a good specimen. You can really know, does the child have a urinary tract infection or other symptoms that could be. And it's absolutely a straight catheterization. Now, many times parents want me to put a bag on their infant. Oh my God, the baby's too little, you're going to hurt them. And you have to explain. We know that infants are immunosuppressed, right? We need an accurate urine specimen the first time. We don't want to have to keep putting them on different antibiotics, as in their kidneys could be damaged from all of that infection in their urine, right? So, bag urine, no matter what you clean, there's still skin contaminants there. It's not accurate. To do a straight cath, you have the parents hold the arms, give them that good old pacifier, right? With sugar water on it, and have somebody hold that infant's legs easily. And with that distraction, in, out, it's done. And the infant's more upset they're being held down than from the catheter itself. So, I mean, I've had mothers and fathers both, are against it. But understanding that we're trying to save kidneys and treat an infection once, they actually will say, okay, I understand. So, what is the purpose and function of the family? It's a safe place. They can develop well. It's where they learn who they are emotionally, their cultural attitudes, behaviors, beliefs. It helps them figure out who they are. Okay. It's nothing, we don't go to that financial. It's more of, what they give them to grow and to feel good about themselves and give them comfort. That's what a family does, should do. The primary goal in caring for the child with cognitive impairment is to what? You have a child who's delayed. Let's say they're that cerebral palsy child, that Down's child. And the goal is to have them be the best they can be. You know, years ago, when I was still in high school, I used to go to a center for the Downs children. And I was there, and all we did as volunteers, and what I watched and observed, there was all the therapies. What we would do is would feed them, change them, turn them, get them out of bed, put them in bed. They weren't giving an education like speech therapy, how to express themselves. When I was doing clinicals for Cutler Bay, their pediatric site, I would watch these children that you don't think they're understanding, and we would give them this little iPad, and this child could tell you how he was feeling. I watched speech with him, learning ovals and colors and shapes. And it was really impressive that this 7-year-old boy that years ago wouldn't have been taught, today we are. And they could do a little more for themselves. And that's what that optimum development. Let them get this goal, and let's shoot for a higher goal. Many infants require oxygen. What type is best tolerated and accurately delivered? And the key thing here is best tolerated. And that's this good old little oxyhood. Now, most students would put as their answer nasal cannula. Well, let me describe this cannula to you with an infant in mind. Well, number one, you've got these two things sticking up that are sticking in their nose, blowing air, and it's moving and it's tickling. And we take the tube and usually tape it to the cheeks because you don't go up around the ears like you do with an adult. It bothers them. And then they're taking their fingers and they're ripping it off. Now, an oxyhood is just a clear plastic dome, which is delivered oxygen, and we can measure it extremely accurately. That child will be up looking around, sucking on his fingers on a pacifier, and it's accurate and it's tolerated well. So oxyhoods are used a lot in that young neonate, young infants in your newborn ICUs. What is the best practice for school-age children with special needs? You know, special needs could be hearing problems, speech problem, could mean that they're not ambulatory, need a wheelchair. So there's all special type needs. And what they say is today, and they're doing it really well, is they're putting them into regular classrooms. So a child can't speak. I had a very good friend whose daughter at birth had a stroke on her speech center at birth, and she couldn't speak, but smart as a whip. So they gave her an iPad where she could communicate and put into regular classrooms. And it worked well. And she's now in high school doing amazing with that. So integrating them there because they're not less than, they just can't speak. Doesn't make them any less than. A multi. Collecting a heel stick blood specimen on an infant. What and how do you do this? Now, the only time we do venipunctures on an infant is usually only for a blood culture or a bleeding coagulopathy test, like a PTT specimen. The rest we take up, put a hospital approved warmer. Don't put anything in a microwave hot and stick it on the foot. It will burn them. Put that warmer on. And then you're going to use the outer aspect of the heel, not in the middle, because that's where the bone is, that calcaneus bone. You can cause an osteomyelitis. So on either side, and then you're going to use the infant lancet. and it's really not so deep, okay? And the other thing is you're going to hold the foot down. So below the heart. If you put it up, the blood's going to drain. It's not going to have any good blood flow. And then you just squeeze very easily when it's, laying down, and you'll get enough blood out. Take your time. You squeeze too hard, that infant's going to have a bruised heel, and you don't want that. That would hurt. Referrals for cognitive impairment should occur when? Early intervention as soon as you can. As soon as you realize that there's an impairment, we need to institute it. And why are we like so anxious to do that? Well, children are resilient and they're remarkable. And you start doing this little bit of intervention, whether it's speech or occupation or physical therapies, children catch up very quickly. They want to do well, they want to please. That's what children are. So as soon as we can, get them caught up and they'll not even know that they were behind. Down's children have frequent upper respiratory infections. And why do you think? Down's children have this big flat nose. Mucus gets caught up in there. They can't get it out. So it drips down and causes all that mucus. And it goes into their ears also. That's why they have more upper respiratories. A multi. What would be included in the care plan of a patient with moderate cognitive impairment? So, what do you think would make a child perform better? They don't think all that well. We have to, we have to teach them fine motor, gross motor skills, communications. What do you think would benefit them? Well, absolutely that structure, right? And then when you're talking cognitive impairment, it could be to that Downs or to that autistic child, and exposing them to those sights and sounds and sensations. Many of them don't like thick things or chunky foods, or they don't like bright lights or touch. So exposing it does help. And one of the big things is when we're having a cognitively impaired child, remember that developmentally they're behind. So always be careful in selecting toys that are safe. So it might be age appropriate for some children, but for this child, no, it's still not safe because they're not there at that age yet. Okay. And also, when we're doing play activities, make sure that what we're doing is going to be useful in teaching them something. Another multi. Autistic children demonstrate which behaviors? Autistic children. Now, the one thing about autistic children is we do not diagnose them till about 2 years old. But we're going to start seeing some of the things, which is language delays. Some of them don't speak at all, or maybe they have a grunt or a moan, but they don't, say words. These children do not like looking at you with their eyes. They don't want you to touch them. They don't like loud noises. They don't like bright lights. These children will usually be, yes, if we get that used to them being in a room with other kids, they'll be in a corner by themselves, playing by themselves, and they're going to do things repetitively. They'll take a truck and put it on a block, and then take a doll and put it on top of the truck, take the doll off, take the truck off, and then truck back on the block, doll back on top, back and forth over and over again. It gives them comfort. And the other thing is they're not going to respond to you. You can call them. They don't respond to you because they're in their own world. Another multi. Children with autism have better outcomes if so structured routine. You hear how many times we go over structured routine decreases stress, anxiety, better outcomes. Absolutely, kids like that structured routine. And then how do we have this child express themselves? So teach them verbal communication skills. If they are nonverbal, which many can be, giving them a picture board so they can tell you what they want. And just because they have autism does, or even any cognitive delays, like unacceptable behaviors are not acceptable. They need to know their limits and their boundaries, and actually that helps them. And also, you don't need just licensed therapists. Parents at home, sisters and brothers at home can help with therapies also. It doesn't mean just those licensed therapists. That's what that was about. It was a little tricky. A multi. Fragile X. You have Down syndrome, and then you have Fragile X syndrome. Fragile X is the second most common of all the common cognitive delays that we do see. They are similar to Downs. They have an intellectual disability, learning disability, cognitive delays, right? But these children are extremely aggressive. Down's children are lovable. These children will need sometimes to be placed on Prozac and medicines to calm them down for their aggression. And they have facial deformities, big ears and big jaw is part of them. So Fragile X, that's the second most common of all cognitive disabilities. What causes autism? Then I'm going to say is vaccines too. Chickenpox vaccine that came out many years ago now. So genetics can cause it. Yes. Unknown. Yes. Abnormalities in the brain. Yes. All of the responses. Yes. And vaccines do not cause autism. There was a research study, in case any of you heard it. This physician put out this fake research study that said that chickenpox vaccine caused autism. Well, when is a chickenpox vaccine given? Right before the second year. When do we diagnose autism? That is about the second year. So they were trying to blame it on something. They found out that it was false. This doctor had his license removed, and the research study was pulled off, files. But in case you've heard it, it doesn't cause it. Ways children with hearing impairments communicate with others. All of the above. You can put two children with different languages together in the same room and they play. And you're wondering, how did that happen? It's because they know how to communicate with their body and showing them. So all of the above can do it with the hearing impairments. What is amblyopia? Remember, this is a chapter on sensory, and remember, part of your sense is your eyesight, being able to see. So understanding the diseases of the eye. Now, amblyopia is when you have one eye that goes to the outside, inside, up or down, and it doesn't really come to midline. It's a weak muscle that's going on. So, how do we treat this weak muscle in this lazy eye? Well, we need to make that muscle work. We need to strengthen it up, send it to the gym. How do we do it? Let's patch the good eye, make that bad eye work. And it strengthens the muscle. And most of the time, it's comes back and no other further things or surgery or anything needed. I mean, in rare cases, but usually it's just patching the eye, taking it off several times a day. How would you help encourage a preschooler to be less apprehensive when taking their vital signs? Again, you can see these questions are related to that variations in, pediatric care. I mean, adults, you say, here, give me your arm, I'm taking your blood pressure. And a child, it's not going to happen, is it? So again, first of all, you have to get down and you get that rapport, get on their level, sitting below them. Then you got to break the ice, right? And now on their developmental level, you are going to let them see, feel, and touch things that's going to explain to them, show them what's going to go on. And they love to play. So make it play. You could tell a child that it's not going to hurt and they don't believe you. You have to show them, let them touch it. What child may be more stressed when hospitalized? And it's actually the one that's had frequent hospitalizations. And why do you think that? Well, they've probably had a bad experience along the way. I mean, you as nurses, future nurses, we're not always perfect. Things happen, or this child got in a situation, and maybe they got frightened or scared. Well, that one is remembering that and doesn't want it to happen again. So that's why it's that child in there a lot. And one of the comes to my mind is a sickle cell child. What's the first thing I did in the ER when these children came in is to get an IV to get morphine in them for the pain, right? So how many times they've been stuck, and nobody can get an IV in them. And that's that one class of patients, children that I do remember quite a bit being stressed, like, oh my goodness, I got to do an IV. And they would hold off coming in just because of the IV. A toddler has a hard time fixating on a single point. The child's eyes move across the midline. And what this means is it's almost like a cross-eyed. They don't work together. This eye and this eye work separately and they cross. That's what this is talking about. And it's called strabismus. That's that cross-eyed. And then nystagmus is when they shake and wiggle. Okay? So strabismus, it goes across. Amblyopia, lazy eye. Okay? No multi. Safety in administering medications to children include, I think like all of you, if you ever wanted to work pediatrics, I was always afraid of IVs, IV fluids, medications, figuring out dosages. That scared me. So we'll never check a room number. We'll always check a child's name band. And we always are going to look at milligrams per kilogram. That's usually what is used within a hospital system. Would I call out their name before giving their medicine? That's not giving me safety because children may have heard a name and then are just mimicking. So ID band and making sure the dose is correct. What can help the parents to make a baby swallow their medicine? You got this young kid and you put medicine in their mouth and they're dribbling and spitting it everywhere. What are you going to do? They need their medicine. And what if it's an antibiotic that has to go home with? So there's a trick. You take a child, put the medicine in their mouth, and you squirt it slowly into the side of the mouth, never in the back, because you're going to vomit all over you. Never put it in food or formula unless it's a tiny bit, but if it never do a bottle, never do a lot of food because you don't know if they didn't eat it all, how much medicine they took, right? But if you can all of a sudden take a deep breath and in their face quick, they jerk and jump. They get scared and they swallow, and it works well. Now, before COVID, before all the influenzas, I used to blow in their face, but now I teach the parents, right, for them to do it, and it works. You might pinch the cheeks a little bit, but it doesn't make them swallow. It's when you blow in their face, they finally swallow. Treatment for amblyopia involves what? Let's see if you remember. So you cover the good eye and let the lazy eye work. Sorry, your lazy eye, your muscles need to work. So let's get that good eye covered. And now you have to work. The nursing is discussing sexuality with the parents of an adolescent with cognitive impairment. What's important to remember here? An adolescent, sexually, their sexuality, they're cognitively impaired. What is your concern? I mean, just looking at that, I'm worried about, a adolescent with cognitive delay. People are going to take advantage of them because there are that type of people. So these adolescents need to be given a very well-defined, concrete code of sexual conduct. Good touch, bad touch, when to call for someone, what to do if these children as adolescents, many of them, we can teach them. So teach them how not to be abused by some other person. Oh, a child is asking mom about his sibling in the hospital. How can you alleviate his stress and fear? My brother's in the hospital. What's going on? He's been there too long. I want him home. It's not uncommon. There's many things that I used to even do as a nurse, but if the child in the hospital is able to have them make a card, a picture, write them a letter or something, right? And if they're a sick child, or they're bringing them into, let's say, in the ICU, get that child prepared. Sometimes the child life office, you can make an appointment and they can help you prepare that child, especially for, as I said, that really, really sick one. The other things I used to do were things like I used to put them little bows in their hair every day in different colors. And I would send them home to their sisters, right? Those are great things. I mean, we are lucky today we have FaceTime. We didn't have that. Can you imagine poor brothers and sisters? And how about grandma who can't walk, worried about her grandbabies, all of those things. But sometimes it's that little personal touch besides that sort of phone stuff really makes a difference. Makes them feel like they did something. Multi. What are some best practices when a child is in pain? So when a child is in pain, number one, get them their medicine, right? Let them get their medicine in a proper dose. Many nurses are afraid sometimes, especially like with morphine, not to give the whole dose. You just minister slowly, and morphine is actually one of the most studied medicine out there. Actually, it's safe. So give it when it's ordered. Also, distraction. Put on the TV, put on cartoons, iPad, let them play Roblox. I mean, whatever it is, coloring crayons, or sitting down with that child just talking sometimes, that really pulls them away from thinking about that pain, right? And then repositioning. If I had abdominal surgery and I'm laying flat, how would my tummy feel, right? Let's elevate the head of the bed. Let's give him a pillow for his tummy. What if I was in sickle cell crisis? Give me a hot pack, give me a cold pack. All of those work. And remember, doing respiratory care, deep breathing, coughing, incentive spirometry, do it after the pain medicine is working. Don't give it before, because the child's going to do it better. Adult, child, doesn't matter. Make sure they're medicated, and then we'll keep those lungs from collapsing. Multi. Children can be critically ill for long periods of time. How do you prevent pressure ulcers? And yes, children get ulcers, pressure sores. Yes, they do. You think it's just the elderly, right? It is really not. So in, children, we have diapers, so make sure that we change them frequently. Older kids, they have bigger diapers or even chucks underneath, and changing them frequently. Turning, of course, rubbing them with lotion as we turn them to increase that circulation. Using a draw sheet, because if you take and just pull the child, the skin goes against that bottom sheet, and it's not a 600 count Egyptian cotton. It goes, and it's really rough, and it can pull the skin off. Another thing, use blankets, pillow rolls, toys, position them around to hold them up so that they keep like up on their side. I used to use, those little beanie babies for their ET tubes. So when they opened their eyes, they saw their beanie babies. All of those things work. And it was there for a purpose. It was holding the endotracheal tube. And last question, multi-select. Young children can be stressed by being in a hospital. How can you decrease the stress? Same routine, have the parents stay. And as I said, you can go to toys, clothes, pillow, blankie, whatever they like. And you would never, if you didn't have to, limit the visitors. I mean, you don't want 20 people in the room at the same time, but that does help children. Oh, Nana's here. Oh, Tia's here. I mean, all of those things, it does really help. Let's see how we did today. Tay. Good job, Tay. Julie. Good job, Julie. Been a helper today. Thank you. Number one, Felisa. You had a good day after all of that. Awesome. Emma and Britt. So, week 4 is done. I'll have this recording up there, very soon. If you need anything from me, you let me know. The exam grades will be out about 12 o'clock Eastern time on Saturday. If I see your scores are lower and I want to get to you sooner, I will notify you. So if you don't hear from me, you've done okay. And as I said, I'm going to be looking through all of those maths, making sure that you all are getting it correctly, because I don't want you to miss a point with math. That's something that we can help with. Any questions at all? Start getting me in your pediatric assessment project topics, what you want to do. I'm not going to have all of one subject and nothing of something else. So the first people in get the choice of the projects. I already have 2 people in. And again, go back, check your NCLEX and your CJ Sims if you have zeros there and you turn something in. And if you haven't, please get them in by Sunday. It is a lot of points. 1 NCLEX and 1 CJ Sims is 2.5% of your grade. So knowing that, try to do your best. Goodbye, guys. Thank you. Let me know if you need something.